Thank you so much, Liz. That was brilliant. And last but not least, Dr. Alice Chen, Deputy Director and Chief Medical Officer from the San Francisco Health Network and Professor of Clinical Medicine at UCSF Department of Medicine.
And I also speak Mac, so is it just the arrow?
Yeah.
Okay. Good afternoon. You guys awake after lunch? Okay, great. It is such a pleasure to be part of this discussion around improving access and equity of care for people with serious illness. And my hope is that I'm going to provide you some useful insights from San Francisco's safety net. Okay. This one. Oh, the big green. Okay. Oh, that big green arrow. Yes. Okay. All right. So what I'd like to do is start off by reminding us of the bidirectional relationship between health and poverty, underscore the critical role of the safety net in ensuring access and equity, explore some of the vulnerabilities our patients face. You've heard many of them already, but want to touch upon those that our patients face that impact care, and then share some promising interventions. All right, so I'm going to start by exploring this bidirectional relationship, which some have dubbed the health poverty trap, right? So if you think about it, it's pretty clear if you're poor that can have an impact on your health, right? If you're poor, you're less likely to be insured, particularly if you live in a state that has an expanded Medicaid. Even if you are insured, it's more likely that you're not going to have ready access to high-tech solutions, new pharmaceuticals that are very expensive, even sometimes basic specialty care. Then there are the environmental factors, which typically are really focused on, if you're poor, what do you get to live? They're the direct toxic effects. You have lead in the water. You have air pollution around housing that's located next to freeways. But then they're the more diffuse, pervasive aspects. So if you live in a food desert where you actually don't have access to fresh foods, fruits and vegetables, if you live in a neighborhood where you're disproportionately targeted by tobacco and alcohol companies, if you're living in a neighborhood where you can't go outside and exercise, all of those then lead to behaviors that you can't eat healthily, you can't exercise, smoking, alcohol, which leads to poorer health. It's also pretty intuitive that poor health has an impact on poverty, although we don't talk about this as much, right? So if you have serious illness, if you're debilitated, it is a barrier to educational attainment, to employment, decrease in income, significant out-of-pocket costs, which lead to medical debt. And all of this actually is not theoretical. There's a really tangible aspect to it, where if you look at the top 1% of men in our country by income and compare them to the bottom 1%, there's a 15-year life difference. So again, you see a lot of parallels in the LGBT discussion we just had, but 15 years difference for men, 10 years difference in women, very tangible, very real. And a lot of these patients who are in this health poverty trap end up being taken care of in the safety net, which the Institute of Medicine defines as those providers that organize and deliver disproportionately serve uninsured and Medicaid patients. In California, the foundation of the safety net is community health centers and public hospital systems. That's true of many places across the country. And for better and for worse, safety net systems are more important than ever. So if you look at the uninsured, we were steadily decreasing after the ACA until 2017. And in the last 2 years, we've had an uptick in the number of uninsured. And again, many of them come to the safety net. And then Medicaid. At this point, Medicaid covers 1 in 5 Americans. In California, it's 1 in 3 Californians. If you're someone with serious illness and disability, 4 out of 9 are covered by Medicaid. This is not a niche program. This is a major piece of our healthcare system. So who are we talking about when we talk about safety net patients? So I figured I'd share a patient of mine. So I take care of a 61-year-old monolingual Spanish-speaking woman who has severe deforming lupus. So those are her hands on the right-hand side. She lives with her 88-year-old mother and 23-year-old daughter in a single room. And that's their room. That's essentially their house. They share a decrepit bathroom and a small kitchen off of a hallway with several other people who each rent rooms on this hallway. She is the full-time caregiver for her mother, who has not left this room since November of last year, including to use the bathroom. She also serves meals at a local school several times a week, in part so she can get a free lunch. And over the last 2 years, there have been 2 times where her insurance had a glitch and she couldn't get her lupus medications for about 4 to 6 weeks until we sorted it out, at which point her lupus flared, and it was that much harder for her to take care of her mom. So these are the kinds of patients we're talking about. And as you can see, she has a multiplicity of needs. I think of our patients in the safety net as canaries in the coal mine. So in the safety net, we have more patients with more vulnerabilities, but frankly, in any healthcare system, you have patients with these same vulnerabilities. You just have to look and you just have to ask. So in our system, just to give you a sense of the magnitude, 35 to 40% of our patients are limited English proficient, LEP. 40 to 50% have low functional health literacy. Depending on the setting, but in our primary care settings, about 40% have food insecurity. Housing, 9% are homeless, and that doesn't count patients like mine where you could argue she has very marginal housing. And then insurance-wise, about 80% of our patients are covered by Medicaid, and that includes people who have Medicare, so the duals. The problem is we don't have systematic data. We have kind of cross-sectional survey data. So that's the graph you see on the right is from a 2015 survey of about 1,000 parents in our pediatrics clinic. And you can see that many people have multiple needs, but really the things that rise to the fore are themes that you've heard throughout all the talks. So difficulty paying bills, food insecurity, employment, housing. Those are the things. Now, this is the thing. When you're in a healthcare setting, this can be overwhelming. The need is real. It can feel very overwhelming. The good news is there are a lot of interventions you can put into place to buffer our patients. So in San Francisco, so I'm going to pivot now and share some of the good news. One of the things that we've always had is a commitment to universal access to care. So prior to the ACA in 2007, we established Healthy San Francisco. How many of you have heard of Healthy San Francisco? Okay, all right. Well, at the time, it was pretty radical. What it did was it's not insurance. It's not portable outside of San Francisco, but it's universal access in the sense that any San Francisco adult resident, regardless of pre-existing conditions, regardless of documentation status, up to 500% of federal poverty level is eligible for this program. You enroll, you get a card, you get assigned, this is people, uninsured people. You get a primary care provider and a network of care that includes specialists, diagnostics, acute care, pharmacy coverage, importantly. At its peak, we had about 65,000 people enrolled. The good news is California and San Francisco have been really aggressive about implementing the ACA. Most of those people are now in Medicaid or covered California, our state health exchange. So we're now at less than 14,000 people. But the key thing is, remember my patient I told you about? Even though she fell off her meds, I was never worried that I couldn't get her back on because I knew we had Healthy San Francisco as a backup. So we've also talked a lot about screening. I did just want to say in our system, for example, we actually systematically screen people for race, ethnicity, language. That's why we have actually data on LEP. We also screen for sexual orientation and gender identity, which is something that's pretty widespread among the public hospitals in California now. What we don't do, surprisingly, is systematically screen for all those social needs, partly because you are opening a can of worms with that. And so what we decided to do, we're in the process of implementing an enterprise EHR, and we've taken our experience and our cross-sectional studies, and we've actually embedded those data points or those fields into our EHR so that we're collecting data on those social health-related social needs that are most prevalent and most pressing for our patients. And the thing is, data is necessary, but it's absolutely not sufficient, right? You need an effector arm. And so this is really the exciting piece, which is even though EHRs, I don't know, I guess they're sexy. Not when you're in the middle of implementation, but technology is always sexy. But this is the real work where you actually have people who are acting on the data. So in all of our primary care clinics, we've actually developed primary care behavioral health teams. We have behavioral clinicians who do short-term counseling around things in this dark green box, so things like IPV, elder abuse, smoking cessation. But then we have the behavioral assistant in the lavender box who is addressing all those health-related social needs in the bright green boxes. And while we're not there yet, our goal is to actually do universal screening and connection, both through the data collection and then kind of deployment of our effector arm for our patients. All right. So of all the health-related social needs, I would submit that food insecurity in some ways is the most egregious in a wealthy country like ours. It's also one of the most kind of the ones that has the most face validity for health systems to address. Because if you can think about it, a lot of cultures have food as part of healing frameworks. It's also true that you don't really need an RCT to say that if you don't have enough food, that's bad for your health, right? At the same time, health systems have really only recently realized the extent to which Americans are food insecure. So across the United States, about 12% of American households are food insecure. When you look at Latino and African American kids, it's twice that. I mentioned to you in our primary care clinics, it's 40%. And this is actually the benefit of universal screening, which is if you don't ask, you actually don't know, even in the population like ours. So 40% in primary care, 60% in our diabetes clinic. It's very eye-opening. The other issue is, it's not just do you have access to enough food, it's what kind of foods do you have? We talked about food deserts. So I'm just going to share with you, last week I was talking to this patient of mine who's a 56-year-old gentleman with really poorly controlled diabetes. And the first time I asked him, what vegetables do you eat? He said potatoes, fried, home fried, he does himself, corn, and canned green beans. And that was it. He has never in his entire 56 years tasted broccoli, cauliflower, Brussels sprouts, eggplant. I mean, didn't even bring up asparagus. I mean, I just went down the list. Have you ever had this or that? He's willing to try, he's willing to eat lettuce and tomatoes, but it's really hard to come by where he lives. And actually, where he lives, they just opened a deli. And so now they have fresh food, but it's mostly in the form of processed meats and sandwiches. Right? So it's patients like these that really led us to start our food pharmacies, which I am actually, we can have a separate conversation, a little bit deeply ambivalent about. To Marshall's point earlier, I really don't think the healthcare system is well equipped to be food purveyors and things like that. But I do think that there is a really important role for us to actually raise the visibility of this issue. So we actually have food pharmacies at our hospital and several of our clinics that's coupled with nutrition services, cooking demonstrations, and importantly, linkages to other food resources, including SNAP. We're also ground zero, let's see, wrong button, for this Medicaid pilot. So a group at San Francisco General actually did a study with HIV patients showing that for food insecure HIV patients, giving them therapeutic meals actually increased their adherence by 50% in their control of their disease. And based on that, and another small study out of Philadelphia, the California legislature has allocated $6 million over 3 years for a trial of medically tailored meals. And so for 1,000 patients who have been hospitalized with CHF or diabetes, they get 90 days worth of meals to see will that actually impact ED visits, hospitalizations, and SNFs. All right. So the last piece I want to talk about is bridging the digital divide. So I had mentioned to you that we're implementing an EHR. Technology is all the rage, particularly in California and in Silicon Valley. You know, an app is going to do everything for us, right? But in all seriousness, technology has incredible potential to transform how we interact with patients, patient engagement, empowerment. There's also a big risk that we leave people behind. And so what we found with our patient population, I already told you the statistics around limited English proficiency and health literacy. Our patients have a lot of difficulties navigating even a basic patient portal, and that has to do with health literacy, limited English proficiency, with computer literacy, with access to the internet, with use of email. So things that we all take for granted. We've noticed that when we actually do observational studies, it takes them longer to complete any given task. They're more likely to misinterpret a test that they do look up on the portal. They're more likely not to be able to find that visit summary that's supposed to be there for them. So what we've done is really developed some basic trainings in multiple languages, both in person and video. You can see that we translate all of our brochures. This is about our patient portal into 5 languages. The other pieces, we really advance the use of proxies, particularly for older people and people with limited English proficiency. Getting someone else to be their interface to leverage the data has been really successful. So, just want to acknowledge my colleagues. I did want to just say that not everyone has direct exposure to safety net systems and patients. I do think if you start looking, you will see these same issues, maybe not as evident, and I'm hoping that some of these innovations and solutions are ones that you can use. Thank you.